Yes.
Yes.
Okay. This is Bijadi Mukunda. I'm the chair of the Board of Trustees. And it's my distinct honor today to introduce Dr. Rupesh Raina, who really needs no introduction. He's the president of APNO. He's an adult pediatric kidney disease hypertension specialist nephrologist at Akron Children's Hospital and Akron General Medical Center with Cleveland Clinic Foundation. He's an associate professor at Neomed Medical University and Case Western Reserve University. He's also on the Council of Internal Medicine at Neomed. Dr. Raina, welcome, and please start.
Thank you, Dr. Mukunda. I also want to tell all the participants I have an honor today that joining this presentation is Dr. Timothy Bunchman, and he doesn't need any introduction. He's the father of pediatric CRRT, which I'm going to get started with my presentation. And I also have my chair of the internal medicine Neomed, Dr. Niemer, and the pediatric nephrologist, Dr. Jim Previs. I was his resident, so it's a pleasure to have you all join the conference. So let me start my presentation, and my presentation started in 2009 when I was a fellow in nephrology in Cleveland Clinic. We had this epidemic of the H1N1 in 2009, and we found out that around 17% of the hospitalized subjects, they were positive for the H1N1, and the AKI at that time was evolving, but 42% of them, they have the AKI, which is stage 3, and majority of them are very sick. The mortality was high at that time when H1N1 came in, because most of the people who require the dialysis, the mortality rate was 50%, and we found out that obesity, CKD, and elevated creatine kinase, which is a rhabdomyolysis, when your muscle necrosed, was associated with the bad prognosis. Then when I'm practicing, this whole epidemic, now it's now pandemic of coronavirus came along, and you can see the total deaths are rising, the peaks, and you can see it's all around. The knowledge of coronavirus is actually evolving. Every day I learn something, I learn the pathogenesis, and I see how the mortality and morbidity is progressing, and how this genetic drift of this coronavirus is also affecting the pathogenesis, and how it is different from one host to the other host. If you look around, the initial report, the AKI was not very serious. It ranged from 3 to 9%, but subsequently you can see it went up to 15%. And this is our ASN consortium, which has shown the AKI is ranging anywhere between 0.6 to almost going to like 11.4. Now, this is another paper that I have submitted for Frontier in Pediatrics as a position paper with Dr. Bunchman, who's joining me in this call. And we found out the incidence in the pediatrics is very bare minimal, like 0.8 to almost going to 1.7%. And I will come to that epidemiology a little bit later. Now, this is very important as a pathologist for us to see what exactly the pathogenesis is, because that will give us the stage for our mechanism of the COVID-19 in the kidney. And I have tried to put this very beautiful Nature publication, which shows that this virus actually attaches to the ACE inhibitor. It is a spike which they have, and they are actually attaching to the ACE receptor. And then what happens is when it comes inside, it has this mechanism of endosomal cathepsin, which is like TMP-RSS protein. And then what happens is this protein, when this vesicle, it just kills the cell membrane, and this virus protein, then it replicates and produces the mRNA, and then it attaches to the ribosomal protein, and that translates into the virus structure, produces the viral RNA, and this is how it replicates inside the cell. Now, if you look around the vaccines that we are working around all around the world, especially in US and also in some developing country, they are mainly focusing on these spikes so that the virus does not come and attach to this ACE receptor, and this vicious cycle of the involvement of the ribosomal RNA and then transcribe into the mRNA, and then replication can be stopped. Now, what does the pathology of this virus means to the nephrologist? When you look into the AKI, the pathology and the way this is affecting the kidney is basically 4 mechanisms that has been eluded. Number one is a maladaptive response to the immune cytokine storm, which I'll come up to the later. Then hypoperfusion related injury, which is very common when you have the MODS, which is the multi-organ dysfunction syndrome that can cause that. We are also seeing in this patient rhabdomyolysis, which is very common. And I've seen the same rhabdomyolysis experience when we have H1N1. Now, this virus is also have a direct effect, which is because the ACE2 are expressed into the renal tubule epithelial cells. And now we have some case report of the collapsing of the kidneys shutting down, killing the filtering unit, because this epithelial cells and glomerulus have this host for them, because these viruses are attaching to the spikes to the ACE receptors, and they induce the podocytopathy. And definitely the drug-induced toxicity is there. So is this a time of nihilism is over or not? It's kind of a learning curve. This is a very nice article, and I try to summarize. So what we are seeing is we are seeing the acute tubular necrosis. Why is that happening? Because this virus attached to the AC2 receptors, which is expressed in podocyte, in proximal tubule cells, it causes the leaking of this membrane, and they get proteinuria and hematuria. Then some of these TMPRSS and other proteases are also present in the tubular cells, and they are causing the priming of the disease. There's a new case report came out in one of the patients who has APOL1 gene, which is actually a gene which predisposes the patient for the FSGS. And this patient got COVID-19 and developed a collapsing glomerulopathy, which is more or less like an FSGS pattern that you see in HIV. Although you see the mechanism, the entry of this virus is actually very much similar to the HIV virus, that it attached with the group 40 protein. And this patient has the biopsy proven collapsing nephropathy because of that. Then it also have the nucleocapsid protein, which is present in the kidney, can also predisposes. This is a beautiful article by Pan and his group. What he has shown is the ACE and the TMPRSS gene, which I showed you before, is very important mediator for this injury, is present in our epithelial cells of the kidney. And also both of them can co-expresses in the proximal tubule. And this is the concentration of these ACE and TMPRSS protein, how they are present everywhere, including podocyte, including descending cells, proximal cells. So this is a very fascinating pathophysiology, how this virus is actually acting all around into the kidney cells. Now, when you talk about this renalism syndrome, what are you going to see as a primary care when you see these patients? You see a AKI, which is in a critically ill patient. You see some fluid balance issue. You definitely are seeing the kidney involvement. You are seeing the cytokine storm. You're seeing the direct viral cytotoxicity, which is, I told you the mechanism, how it attaches to the podocyte. You're seeing some muscle injury. The other fascinating thing is, which I'll show in the next slide, you are seeing some hypercoagulopathy, which is more or less like a HLS syndrome. And some of these kidneys are just having a collapsing. For the people who are not in medicine, which are attending this seminar, is just your filtering unit is just necrosed. This is a nice summary I have for the clinical spectrum on the patient. You can see proteinuria. The mechanism of proteinuria is very much like the injury to the filtering unit, to the podocyte. It just attaches. It's the same mechanism what you have for the membranous. Then we see hematuria, we see rhabdomyolysis, we see proteinuria to an extent of 3+ in a dipstick, and also some nephrotic range proteinuria. Now, how long this lasts? This is more or less like a viral nephropathy, which we see in other spectrum, and it may last for 6 to 9 months, but this is a spectrum you're seeing when these patients are not in an acute setting or in the ICU, they are presenting to you in a normal office with the evidence of AKI. Now, this is what is known as the secondary hemophagocytic lymphocytic syndrome, which we are seeing in this patient. I have with me Dr. Sanjay Ahuja. Actually, he's a hematologist oncologist in the Rainbow, and I was a fellow, and we did some work similar on HLH. What the studies have shown, this patient should be screened for any kind of laboratory parameters like ferritin, decreased platelet count, or ESR. And these patients are having some kind of a secondary hemophagocytic syndrome. Now, this is a very complex biological diagram, which I have put in there, which shows any kind of infection can actually trigger the uncontrolled immune mechanism. And what it causes is it causes the immunological burst that affects the hemopoietic cells, endothelial cells. And it has been shown in Wuhan experience that elevated ferritin and IL-6 was the two independent markers for the mortality. Now, how does this HLH patients are presenting? We have two patients actually presented with the similar syndrome in my hospital. They present, these are the criteria of HLH, and that can actually occur in any infections triggering the endothelial cells and damage. So this is a paper that we have published in the Renal-Occlusive Disorder, where we have the similar pattern, but these patients have the bone marrow transplant, they developed the endothelial injury, they did not respond with the fluid overload, and they have the similar pattern of HLH, and we started the CRRT early, and these patients, they got better. So what are we dealing in an acute setting when I am rounding in the ICU? The biggest problem with this kind of bacteria is the cytokine storm syndrome. I remember this concept was brought to me by Dr. Bunchman about 6 years ago. And he was the one who started doing the study with the patients who have a septic shock and starting the CRRT, which is a continuous renal replacement therapy. And he has shown, which the study was not completed, that the CRRT can remove these interleukins. This multi-organ dysfunction syndrome with a renal involvement, what we call cytokine storm, in the setting of the COVID-19 is very drastic and very quick. Patient comes to the hospital, within 3-4 hours, they go into the need of the oxygen, and within 12 hours, I can see them going into the ARDS syndrome. What studies have shown, what are the cytokine storms are, the cytokine levels like interleukin 2, 7, 10, and also interleukin inducing protein, granulocyte stimulating factors, macrophage inflammation protein, and tumor necrosis syndrome, tumor necrosis alpha protein. Now, the two, IL-6, which is a very potential at this point of time where people are targeting to treat that, is shown in the multiple studies as independent marker for mortality. Now, how the cytokine storm is happening, as I've shown in my previous slide, that it attaches with the, on the spike, it goes inside, it replicates, and then it produces the mRNA engulf into the protein synthesis through the ribosome. And these viral protein, this viral inflammation, chemokine burst, causes the multi-system organ dysfunction. This is a beautiful paper published by Claudio Ronco. As you know, that Claudio Ronco is the father of the adult CRRT, and the ped CRRT is Dr. Bunchman, who has joined me in this presentation. What he's doing in Italy, he's based at Italy, he has seen these biomarkers. You can see these interleukins, TNF-alpha, IL-10, IL-6. They come very short within 12 to 14 hours. They damage, they cause shock, it causes kidney disease, liver disease, and it causes multi-organ dysfunction failure. They were lucky enough to have what phenomenal circuit known as the cytosol. And what he did in his experience was these patients, they come, they have a coronavirus infection, get respiratory failure. And when he sees them patient going into this kind of a syndrome, which occurs between 12 to 24 to 36 hours, he has attached with the artificial kidney, which is CRRT, the cytosol. And he has shown when he attached this cytosol in parallel to the CRRT, the chemokine burst can be mitigated or can be stopped. And then these patients, they feel better, or at least these interleukins will be removed through this cytosol so that it does not affect multi-system organs. This is cytosol. Now, on April 10th, 2020, it has been approved by the FDA emergency use in the United States. As Dr. Agarwal, who's our lead of the ID for the Summit County, Shanu must be joining me in this presentation, and we were working to get cytosol into our hospital to prevent these chemokine burst and response, and it attaches with the regular hemodialysis. Now, we don't have cytosol. What are we gonna do? As you know, we can do one thing which is known as the CRRT, which is continuous renal replacement therapy, which is convective theory. And this is how the mechanism works. But I try to make it very simple diagram for you. This is a patient. This is an artificial kidney. Now, you take the blood and you try to give blood back and put a negative pressure here, and you take out the fluid, which is known as ultrafiltration. But if you add, but this is a plasma you're taking out of the kidney because of the transmembrane pressure, but if you replace it with the plasma or a replacement fluid, it is known as continuous veno-venous hemodialysis. Now, with that, if you put diffusion, which is a corrector where you put the dialysate on the counter current mechanism so that you have a diffusion gradient, it is known as CVVHD, where you're using the dialysis with convection. But if you do the replacement, ultrafiltration, and dialysis, it is known as CVVHDF. Why this mechanism is so important? Because what's going to happen with that is, with that chemokine response that I was telling you, how the CVVHDF I explain is very simple. That when you stand in the seashore, you will see the waves coming on, and when they go back, they have a lot of shells and everything at the corner. This is exactly the convective theory is. You take the blood, you pass it through the membrane, and that transmembrane pressure, they hit with the convection, and that molecules, the bigger molecules can come off. Now, if you put diffusion, which is a mechanism, you have a counter current mechanism, you also can remove the molecules from the lower to the higher. But CVVHDF, which is a convection, is an important mechanism for the removal of the solute, can take out some of these bigger molecules. We do not have the liberty of the cytosol right now. What are we going to do? How can we remove these potential interleukins, or how can we take away of this cytokine storm? Because to get a cytosol is hard. It is although approved in FDA, but by the time we get it and we'll use it, we don't have any other options. So what we have proposed is known as high flow CRRT. And we have submitted this as a position paper. And what we are proposing is that instead of not using the cytosol, what we are using is a high flow CRRT for 2 hours. And what we do is, these are the ECMO machine, the artificial lung support. This is CRRT, which I talked about, the convective clearance. Initial, we run for 12 hours of a very high replacement fluid of 75 to 80 ml per kilogram per hour, where we remove all the interleukins for 12 to 16 hours. Now, this was the hypothesis that we have proposed, and Dr. Agarwal is with me, and also one of my residents, Abhay Patel, is there. We have like 2 patients that we have tried this mechanism. What we suggested is, if you do this high flow CRRT, where you remove all the plasma with a heavy thing, you remove the chemokines burst. Now, I don't want to go more than 12 to 16. I have only restricted to 12 hours, that Dr. Bunchman can tell me at the end of the talk, or Dr. Previs. We don't want to remove the good chemokines that come into place to combat with this IL-2. And this is a position paper, and I've written with Dr. Bunchman, and my fellow who's also joining me today is Rana Chakravarti, and we have proposed this for the children's until as we get the cytosol and we can treat that. So we have tried this 2 so far in the SUMA, and both of the patients, they did well. After this heavy high flow CRRT, we have changed them into the regular flow. Now, where this concept of the high flow CRRT came in, and this is, we have just published a paper in Nature as a position paper for hyperammonia. These are the things were used in the inborn error of metabolism patient, where they have a high ammonia and they produce very quickly. It's very hard to actually to fight with the levels, and we use this high flow CRRT, and then they switch it to the lower flow when the endogenous production is gone. So this is what we propose for the patients, and we'll see how the things will go. Now, the second thing is we talk about the hypothesis of this ACE and R. Now, this is very fascinating hypothesis. What happened is, the first one is that severe infection with COVID, what happened is they enter the cell through the ACE inhibitor. So if you have ACE inhibitor, which is that converts the angiotensin 1 to 2, you will actually direct or open these receptors a lot for this virus spike to come, attach, and attack. On the other hand, if you look, the hypothesis number 2 is, if you do not have an activation of the angiotensin 2, it also is protected to the lung injury, because what's going to happen is the virus does not go and causes the inflammatory fibrosis because of the angiotensin 1 and 7. This was a hypothesis, is it created the whole concept of using ACE and R during the COVID-19 or not. So what we came up is the data on hypertension, on the RAS blockade, and COVID-19 are currently, it's inconclusive. There is no data, it's a hypothesis. Current evidence come from unadjusted or inadequately adjusted studies, making them highly prone to the selection bias, misclassification bias, and confounding due to age, duration, and a type of hypertensive exposure. ACE and TMPRSS2, which I showed you before, when how this virus act and causes a chemokine burst, is a target of the therapy, but patients who are taking ACE and R for hypertension are not advised, I'll repeat it again, are not advised to change their therapy unless advised to do so by their physician. And as I said, there are two hypotheses. One says the virus can replicate more because you have more availability of the ACE. The other hypothesis says that RAS inhibition can be protected and it can decrease the lung injury because angiotensin 1 and 7 can inhibit the inflammatory fibrosis. What's going to happen to the hemodialysis patient? Because they are the Achilles heel in the pandemic. Now, I get a lot of calls, and Dr. Mukunda and we had actually a table conference with with certain insurance company. How are we managing the dialysis patients? Because this is a very tough avenue for us as a nephrologist. Now, how the dialysis patients are classified is they are COVID-19 positive or they are under the investigation. Those people who have been tested for COVID-19 are awaiting the results. A person who has not been tested for COVID-19, but they have all the features. These two patients, they have treated in an isolation shift within the dialysis unit. And we have one center at certain area, which is only catered to that patients of class 1 and class 2, where they have patients who are positive or patients who are awaiting the results, or person who do not be able to do the test, but they have all the symptoms. That shift is allocated to that patients. And those, they do not change dialysis shift and caregiver staff to avoid cross-contamination and infection. Dialyzing in a place with a rigorous use of PPE in isolation. And we are deferring dialysis and referring patient to a hospital for testing and treatment when it is necessary. There is a third category of the patients who are asymptomatic person reporting a close contact exposure to COVID-19. And these patients who reported have a close contact exposure to a person who are suspect to a confirmed COVID-19 patient, yet does not have a sign like fevers or lower respiratory symptoms, for purpose of this policy are also isolated separately. They moved into the isolation shift with only other asymptomatic close contact exposure patient. asymptomatic patient should never be treated in the same isolation shift as a COVID positive patient for PUI. I just got a call today. I have a patient whose wife is positive for COVID-19. And he comes to our dialysis unit. She came positive in the morning today. And I said, he's actually an asymptomatic person at this point of time with a close contact exposure to his wife with COVID-19. So I have to move him into the isolation shift with only other asymptomatic close contact exposure. And that shift has only 2 patients because these patients are not very much evident. But I don't want him to go with the class A or B, where you have the patients who are under the investigation of COVID-19 positive patients. This is what the world that you should change your trend, bring more home dialysis. When you have a CKD patient, you do the pre-dialysis education, try to do a home dialysis. This is the perfect scenario where the patients are doing very good on a home dialysis. This is a paper published in Seminar in Dialysis. And now you can see there should be a lot in the current pandemic, rapidly increasing the use of home dialysis, which is very critical because it promotes the substantial increase in the prevalence of home dialysis. It greatly reduces the risk for COVID-19 patients in both patients and the staff, which is needed to care to them. And we should be reducing the risk to the entire community. And this may be a paradigm shift, but Dr. Priebus is also on the call. He's a pediatric nephrologist. And in peds, we do a lot of home therapy, but in adults, that shift, that paradigm, that law has to start now. And we should be focusing more on the patients doing the home dialysis, seeing them once a month, and that will prevent an exposure and also will also greatly reduce the risk for COVID-19. Can dialysis patients recover from COVID-19? They are high risk. For severe case, recovery may take up to 6 weeks or longer, and about 1% of those infected will die from the disease. COVID-19 infection in kidney transplant recipient. It has been reported, and COVID-19 infection in kidney transplant patient can cause severe AKI, and they are getting admitted. We need to have prompt reduction in the immunosuppression. They're already very immunosuppressed. And the patients who are older and diabetes, they are at a higher risk. And this is just a roadmap about the patients who have been diagnosed with COVID-19 and a kidney transplant. And you can see diabetes is a very important risk factors. And some of them, they have high D-dimers, ferritin, troponin levels, and they also have lymphopenia. Again, it is a chemokine burst on this immunosuppressed patient. You can get HLH phenomena in this transplant patient because they're already primed by these transplant medication. Now, what is a statement from the American Society of Transplantation? The risk of acquiring COVID-19 from organ donation is low. Donors are screened for COVID-19 symptoms, exposure history. Living donor who has been to the high-risk area exposed to someone with COVID-19, we need to ask them to postpone donation. Now they move from 14 to 28 days. Some organ procurement organizations are actually testing some or all donors for COVID-19. CDC made recommendation about elective surgeries and non-essential procedures that include transplantation. Transplantation should not be postponed in high acuity and unhealthy patients, but living donation we are holding at this point of time. Some center may still need to look at temporarily putting this elective living donor transplantation or non-urgent disease donor transplant on hold. Living donors have been asked not to travel to a high-risk area for at least 14 days before donation and monitor for the symptoms. Now, information about the recent travel and possible exposure is also very important. And I have a lot of patients, like 4 or 5, waiting for the living donor. And what I'm doing is every week I need a card from them. Do you have any symptoms? Do you travel anywhere? Do you come in contact with any patient? Because now, as you know, the Ohio governor has given a green signal for doing some of these elective procedures. Some centers are doing the transplant, but we are on hold at this point of time. We just do it on the case by case, and donated kidneys are screened for COVID-19. If kidney tests positive for the COVID-19, the organ cannot be used for the transplantation if you are positive. If the kidney test positive from the donated kidney has COVID-19, it is not a candidate for the transplantation. to any other recipient. Post-transplantation or other high-risk patient may be at a higher risk for severe disease for COVID-19. And for severe cases, recovery may take up to 6 weeks. Kidney transplant, I'm not going to go into detail. In our opinion, insufficient evidence is available to consider kidney transplant as a safe procedure in COVID-19 pandemic. In emergency situation, in case of no vascular access, unfeasible dialysis, or hyperimmune state, the benefit may outweigh the risk, and it depends on the case basis by cases. And there is a pressing need to exist to evaluate the positive solution to reduce the risk of kidney transplantation procedure during COVID-19 pandemic, and also for research to address the sensitivity issues of the diagnostic test for COVID-19. Each case should be assessed, should be evaluated before putting them into the, or assessing them for the transplant. At the end, I want to thank my senior research fellow, Ronit Chakravarti. He has been very active and prolific, and research fellow, Nicole Nair. I have my research students, Aditya Sharma, Hirva Joshi, Joel Wong, Katyani Sharma, Richard Dua, Leena Niemer, Paul Niemer, Rahul Jain, Arul Khatri, Shyam Polakhanda, Jubin Mahajan, Prabha Vashisht, Mahi Mistry, Meredith Decoy, and Pujajit Carey, because all these research that we have been doing will not be possible without my research student. With that, I will end, and I will give 30 seconds to Anna Tisnes. She's our VP of the National Kidney Foundation, to just say about 2 or 3 initiatives that we are doing as a medical advisory board, and from the local Northeast Ohio for the National Kidney Foundation. Anna, if you're there, can you just spare like 2 or 3 seconds?
Of course. Thank you, Dr. Raina. And wow, what a fantastic presentation. Thank you for that. Like Dr. Raina said, my name is Anna Jinnis, and I'm the Executive Director at the National Kidney Foundation serving Northern Ohio. I wanted to just take a minute and let everybody know that within this pandemic, the National Kidney Foundation is working really hard to advocate for the rights of kidney patients, to get more PPE equipment, signing letters, working on the expansion of paid family and Medical Leave Act, and really sending out open letters to treating COVID ESRD patients across the board. So please know that we are working very diligently alongside you all, and I wanted to just let you know that we have an advocacy and action blog on the website. If you can go to www.kidney.org/coronavirus, we have tons of patient information for coronavirus. We have professional education information for virus as well. So please check that out, kidney.org/coronavirus. And the Medical Advisory Board, who includes, of course, Dr. Raina, are so incredibly instrumental in just disseminating this information and making sure that our patients are safe and healthy and well. So thank you, Dr. Raina, for the opportunity. And if anybody has questions or wants to get involved in advocating for our patients on a state or federal level, please let me know, and I'll welcome that.
Thank you, Anna.
Rupesh, Tim Bunchman, may I ask you a question?
Yes, Dr. Bunchman.
First of all, excellent talk. I apologize. I've only been paged out twice, so only heard 2/3, but the 2/3 I heard was excellent. But my question is the hypercoagulability issue. What I'm reading is they almost have a TMA-like phenomena. Any thoughts on optimal anticoagulation, if dialytic therapy is necessary, rituximab, eculizumab, any ideas?
Very good point, actually. I don't know whether Shanu is on the line or not. We have like 2 patients. One was exactly acting like an atypical HUS presentation, has an endothelial damage. And actually ARDS is not what we are thinking as an ARDS that we had in the setting of other patients. What we are thinking is it's actually activating the complements. And
right.
One patient we have got an eculizumab, got transferred from the other hospital in our setting. He got everything, ILC blocker. But at this point of time, I don't know these patients. I'm learning every time when I go and see these. But definitely the ARDS, what we see in sepsis and multi-organ dysfunction, it is not. It is a mechanism of endothelial damage triggering the immune complement system and it is behaving as an atypical HUS presentation. For the people who are not in medicine, atypical HUS is that you have uncontrolled activation of your complements and you start chewing up your own blood vessels. So you exactly nailed it. It is coming along as a phenomena of endothelial damage, atypical HUS and HLH phenomena. And that's why we are proposing the CRRT much earlier than waiting till you see the uremic FOST on the forehead.
Yeah, this is Shanu. Shanu, I'm on the line as well. Can you hear me?
Yes, so Shanu is our ID and she's a lead of our Summit County, and Shanu and I have been working on this CRRT protocols and heme on these COVID-19 patients. Shanu.
Yeah, and just to answer the question about tocilizumab and the IL-6 inhibitors, you know, their experience with doing this since the first week of March, what I can say is at this point, we're still waiting for some of the big centers. A lot of these medications are only given under clinical trials now. At this point, we are still, we do administer these drugs at our institution, but we are keeping a registry. What I can say is that the tocilizumab, I've seen benefit in patients that it's given at the right time, when you have to almost predict that they're going into a cytokine storm. If they've already gone into the storm, starting to develop ARDS, I have seen very limited benefit of it. And that's kind of a question for you, Rupesh, is if we consider CytoSorb or the high flow CRT, is it only in patients that have renal compromise, or is it something that would be suggested in patients who the renal function has still been preserved, but then they are still going into a cytokine storm?
Very good point. And I think this is something what we are proposing, like a renal replacement versus renal support. I think I don't have to wait for the renal failure for that. I can do it for like 24 hours. Shanu, we had that case that got transferred, and from FiO2 of like 100% to 60 to 40% in like 12 hours. Yes, it could be used, but you know, has its own challenges changing the concept of renal support to renal replacement to renal support. But thank you. We have done it with 2 of your patients and they benefited. Yes, it can be done.
Okay, thanks. And then I think the other question with the anticoagulation was the question of whether we're giving full dose anticoagulation. Was that the question that was asked?
Yes, that was Dr. Bunchman's question.
Yeah, at this time, the anticoagulation issue is also an unanswered question. What we do know is that these patients should definitely be on VTE prophylaxis for sure. We show everybody is receiving prophylactic doses of anticoagulation and even intermediate doses, but the answer to full dose anticoagulation is still an area of debate. There is some more literature on giving post-discharge anticoagulation for about a month to prevent further clots.
Thank you, Shana. I think with the time constraint, we'll move into the next presenter and we'll take the question at the end. So next presenter it's my pleasure to introduce Dr. Vikas Jain. Dr. Vikas Jain is actually Associate Professor in the Metro Health at Case Western Reserve University, and he's a member of our Executive Committee of EPNO, very prolific member, and he has done a lot of initiatives. Now he'll a little bit make the talk more better, what we deal now, how you live a life, your life in this era of COVID pandemic. Here is Dr. Vikas Jain.
Thank you, Rupesh. That was a wonderful talk. And I will switch gears and talk about very different. And I know this is like Friday evening and we are running against time, so I will try to make it shorter. I will talk about how to live your life in this era of COVID pandemic. As you all know, COVID-19 stands for coronavirus and disease 19. It is because of novel coronavirus. But this virus is going to stay with us forever. After a few weeks, few months, it is not going to disappear. So we have to learn to live with the virus. Most important thing will be to follow the precautions, but do not panic. We have to keep on enjoying our life. We can't keep our life on hold. This virus is going to stay forever. COVID-19 is an evolving situation. A lot of research is happening, multiple publications are coming, and sometimes we are seeing conflicting results. So we know better treatment plans will be available in future. More efficacious medications will become available. Vaccine will come. When? We do not know. It may take few months or more than that. Multiple trials are happening and we do not know the efficacy. But most important thing at this time is to flatten the curve that will reduce the mortality. The current lockdown has prevented the sudden surge of cases within a short span of time, as we have seen in Ohio. So the lockdown has been really successful and the healthcare system is now well geared to save lives. So they have plenty of beds. ICU system is available to protect the lives. So we should follow reasonable possible physical isolation precautions, hand hygiene, face cover, and other precautions even after the lockdown is lifted so that we do not see a really bad second wave. If we keep on following these precautions, then the second wave is going to be smaller. Whenever we move out, whenever we go out in public places, we should try to use face masks. If everybody is using face masks, then the possibility of infection will be minimized. There are so many things right now which are not under our control, but there are plenty of things which are under our control. And right now, like for our personal family life, personal professional life, we should think about the things which are under our control. We should be brainstorming how to adapt, how to change to manage the situation. As I mentioned before, one important aspect is to follow the precautions. We should try to reduce the use of social media, news, and internet. If we are going to keep on looking at the number of patients infected, number of mortality in Europe, India, US, then those sad news are going to make us like feel sad and depressed. Rather, we should be focusing on how to invest our time on ourselves, our community, and our family. Just to repeat, we should be following precautions without panicking. Everyone has a unique situation. We should think how to minimize the risk while performing our professional activities, while performing our day-to-day activities. Frequent hand washing is a must, minimum for 20 seconds with water and soap. Avoid touching face. Use of face covers whenever we go out. We should clean up our work area by disinfectant wipes every day and reduce unnecessary contact. Now the lockdown is going to be lifted, restrictions will be less. There may be a temptation to go out, have gatherings, but we should avoid unnecessary contact and try to keep a distance of 6 feet whenever we are meeting with other people. Learn to greet with others. There are like multiple different methods, verbal, namaste, hand waving, or other methods of greeting. We should brainstorm how to adapt to this new situation. We should be spending more time at home or in non-crowded places even after the lockdown is lifted. We should think, how are we going to utilize the time? What do we want to do? What are our priorities? What makes you happy? Everyone is unique and everybody will come up with different answers, and we should try to focus on those things. We can think about learning new things. It could be a new skill in your profession. It could be completing some CME courses, or there may be some cutting edge technology in your field and you want to take some online courses or read about those. Or you can take some managerial courses. Or you can decide to do something for yourself, but try to do it online or from home to avoid the spread of infection. You can think about reading a book. It could be a non-academic book about Indian heritage or about the heritage of your country or your culture, spirituality. Recently, I read a book on The Magic of Thinking Big by David Schwartz. This is an excellent book. There are plenty of small, short, inspirational stories, and these things can reinforce how to improve, and these things can be really good in your personal and professional life. Emotional intelligence is becoming a very important topic. Emotional intelligence is the ability to understand and manage emotions in an effective and positive way. Improving emotional intelligence and high emotional intelligence can help us to communicate better, diffuse conflicts, improve relationships efficiently, and effectively overcome life's challenges. There are plenty of online resources, online courses, articles, and books available on emotional intelligence. And improving our emotional intelligence can help us in our personal as well as professional life. Now, think about connecting with the kids. In our day-to-day activities and our professional life, we are very busy and we are not able to spend quality time. Now, if we are going to spend more time at home, then think about connecting. And the best way to connect with the kids is to learn and to do what they do. We can play board games, we can play ping pong, pool, card games, chess, but try to do the things what they do. For example, if your kids are into playing Xbox, PS4, try to play those games with them. It will be very difficult and awkward in the beginning. I tried this like last week for a couple of times. For adults, managing those things can be extremely difficult and clumsy, but it will be like meditation. If you are playing those things with your kids for 15-20 minutes, your mind will be completely off from all other things. It will be just like meditation. Talking about meditation, meditation and breathing exercises are excellent for health. They will reduce anxiety and stress. They are good immune boosters. Everybody knows about it. But the problem is very few people do it on a routine basis. So we should think about developing discipline and start doing these things regularly. There are plenty of free online resources. My favorite is Isha Kriya, which is a free guided meditation by Isha Foundation. And this is available on their website and on YouTube. You can use this, and there are like plenty of other guided meditation. Headspace is offering free guided meditation for healthcare professionals. Art of Living is another resource. Yoga is also excellent. There are multiple different yoga asanas, and we should try to do those. My favorite is Surya Namaskar, also called Sun Salutation. You can see these are like different postures. It can provide flexibility. If you do like 10 Surya Namaskar, it will take you approximately 10 minutes. And apart from flexibility, it is also good for endurance, strength, and cardiac workout. If you are in good physical shape, and if you will try to do 15 or 20 of them, it will take you around like 15 to 20 minutes, and you will be short of breath while doing these. And this can be performed at home. Even if you are traveling, you can do this in your hotel rooms. Even if weather is bad, you can easily perform them. Just take like anywhere from 10 to 20 minutes, depending on how many you do. One important thing is to do something for our community. Everybody is unique. They have different passions. They have different skill sets. They have different priorities. So we can help our community in many different ways. It can be performed on an individual basis, or we can join several charity organizations. Apno and Seva has collaborated to do some projects. They are distributing face masks. They have set up a plasma registry, and there are many other charitable organizations which are doing good community work. But we should try to do these things without increasing the risk of spreading the coronavirus. Now, COVID-19 is going to change the world. A lot of changes have already happened. We should prepare ourselves psychologically to embrace these changes. We should adapt to the new normal. We shouldn't try to fight with the change. We should adapt and evolve. Now, COVID-19 and the changes are also going to bring up some new opportunities. Think about new opportunities in your workplace and go for those opportunities. Distant learning has improved a lot. With this COVID-19, all the schools are closed. The college students and high school students and even the younger students, they are learning from home. Even telemedicine is happening, and all the health and all the corporate world meetings are happening online. So we should try to learn more about distant learning. I like this website, which is qt.2020, which was made by a high schooler. Many high schoolers and college students, they do some sort of community work. They go to nursing homes, homeless shelters, and they do peer tutoring. But because of physical isolation, they are not able to do some community work. So this high schooler was very innovative. He thought like outside the box, and he made this website. This website has like two components. One component is how to enjoy, how to play, how to like spend some time for fun, and there are different resources. On the other aspect, there are plenty of resources how to learn and what are the different websites from which either paid or free websites the students can learn. So we should try to be innovative and see and do things which we can do online. Now we can think about being creative. Many of us have some artistic side. Some people like to write poems or articles. So we can pen down our thoughts and post our articles, our thoughts on blogs. Medium is one blogging website. You can create a free account and you can post your articles and share with your friends. Weather is improving and gardening is really good. You can think about planting a vegetable garden or flower bed in your backyard. This will be a really good exercise and you will really enjoy it. We have many friends and relatives, but because of our busy professional life, we are not able to be in contact with them. So this is the perfect opportunity where we can call them and catch up with them, all our relatives and friends in India or other countries or in US. We are very busy professionals. All the doctors, they have very high demand, especially with the COVID pandemic. In addition to this, many doctors are also involved in many professional and cultural organizations, many charitable organizations, and the things can be overwhelming, which can lead to burnout and exhaustion. So we should know how to maintain a good work-life balance, and we must learn when to say no. We have to put ourselves, our family, like our health first, so that there is no burnout or exhaustion. Now, there is a very fine line of being very efficient, extremely efficient, versus doing too much where it is personally harming you. Now think about doing something totally new for fun. It could be music or dance. Music and dance, they are really good stress busters and they can even improve cognition. Plenty of research articles are available which tells that it can reduce the chances of Alzheimer's disease. When I was preparing this presentation, I Googled how to learn dance, and I was surprised. There are many online resources. Some of them are free, while some of them are at nominal cost. So this is one website, which is udemy.com. And on this website, you can purchase a crash course for social dancing if you are going for a party or wedding. And if you do not know the ballroom dance, so you can learn on this website. Let me show you a quick video.
Hello, my name is Leon and this is Kim, and we are the creators of the social dancing crash course for couples, where we're going to teach you how to dance quickly and easily so that you can dance at any social function, including weddings and parties. So if you ever felt foolish on the floor and you were not sure of how to dance with your spouse, your girlfriend, boyfriend, or with a friend, then this course is for you. We are professional dancers with over 15 years of teaching experience, and we put this step-by-step course that will take you from an absolute beginner to a confident social dancer. No longer will you be looking at other people having fun out there while you're sitting there uncomfortably. You'll be able to get out on the floor and have the time of your life. You will learn the basics of 3 ballroom dances: the waltz, rumba, and swing. And we've chosen these 3 dances because they fit most of the music out there so that you'll be able to dance right away to any song. We break everything down in this course, including men's steps, lady steps, the counts. We give you lead and follow tips.
So you can try this out, and this can be done even for the people who are absolute beginners. And I tried this last week. So they start with like really basic steps. Weather is getting better. We can think about spending more time in our backyard. We can enjoy our local lakes, beaches, and parks. So this is a picture from the Brandywine Falls, which is very beautiful. It has plenty of nice hiking trails. Even if you're going out in open, you can keep social distancing, you can keep physical isolation, and there is like very minimal risk of fomite transmission. You can use a face mask, but you can go out. This picture is from Hinkley Lake, which is only half an hour from here. Boating starts after the Memorial Day. They have boating, kayaking, and canoeing. These 3 pictures are from Hocking Hills, which is only 3 hours from here. They have plenty of hiking trails. Some of the hiking trails are wheelchair accessible. Some of them are easily accessible for adults, while some of them are pretty rigorous. It's a very beautiful place. You can spend like 1 to 3 days over there. And I believe after the lockdown is lifted, the state park will open. So rather than making your travel plans of going to Florida or California and like exposing yourself to increased risk in the airplanes, you can think about enjoying the beauty, enjoying the wilderness within Ohio area. So there are like plenty of Cuyahoga National Parks, Hocking Hills, Hinkley Lake. Rocky River Reservation, and there is a really long biking trail along the towpath. So think about going outside within the Ohio area and where you can travel without exposing yourself. Last but not the least, think about making your wife happy. Try to learn some cooking or try to do something at home together, cook together. You will really enjoy it and you will remember this forever. So this is the time, and the next few months, you should think about how can you enjoy your life while doing activities in the house or in your backyard. So to summarize, we should be following the best possible precautions, but we should keep on enjoying our life. We should not keep our life at hold. We have to adapt and evolve and embrace the changes. We cannot fight the changes. This COVID pandemic is going to change the life forever. We should think about learning new things, and you can give to others only when you are happy and healthy. So keep yourself first, and then you take care of your family, your profession, and the community. Thank you.
Okay. I think we can take 2 or 3 questions. We have around 10 minutes.
Dr. Raina, this is Rashid Niemer. I came in with a question to ask you about my patients on ACE inhibitors and ARBs, and you answered very clearly without me asking it, so thank you. The second question I have a patient in the MICU at Cochrane General. He is only 35 years old, and he's been requiring hemodialysis. Now, he did have some CKD 1 or 2 prior to that. His cousin, who they shared the same hookah with, had some respiratory symptoms, and they resolved, and end of story. While he is still for 2 weeks in the MICU with requiring hemodialysis. Has that been the case, that if you have underlying CKD, you're more likely to end up with hemodialysis through your experience with patients?
Very good question, Dr. Niemer, and that is something we have to learn, but definitely, as I started my talk with an H1N1 experience in 2009, CKD patients going into this chemokine burst, AKI 80, and their chances of recovering get a little bit hard because they already have a damage. Second is, most of these patients, as you are experiencing, actually they go for dialysis for a longer time. I have the one who's going for about 3 weeks now. So it is just the injury that already with the damaged kidney, the recovery gets a little bit harder for sure. And don't know, they're so different. And as you said, I'm seeing a lot of young patients. Shanu is in the talk too. They are just very young. Some of them are like 50s, they're 45. And the mechanism, as Dr. Bunchman was saying, can also involve the atypical HUS, like endothelial damage. So it's very hard to pinpoint what is leading it to, but patients with a baseline kidney dysfunction definitely have a prolonged course, and sometime with this repeated bouts of the AKI, they may get dependent on the hemo later on too.
Thank you.
Thanks. Dr. Niemer is our chair of the medicine from NeoMed. I just want to introduce everybody to Dr. Niemer.
Thank you for inviting.
Thanks, Dr. Niemer. Any other questions for me or Vikas?
Hi, Rupesh and Vikas, great presentations. Thank you very much. Enjoyed it.
Thank you, everybody. Thanks for coming and giving your time on Friday evening. And again, thank you to all my research students for helping me work, because this is all your hard work that I'm presenting. So thank you again. Thanks.
Thank you very much. Nice presentation.
Thank you. Thanks.
Bye.
Great presentation, Dr. Raina.
Thank you.
Thank you.
Presentation.
Nice.
Both of you.
Thank you.